Hey everyone, my name is Tristan Seton. I'm one of the third-year residents from Geisinger Health System in Pennsylvania. Thanks for the opportunity to present here today. This is going to be a video case presentation on demonstrating the diagnosis and management of gastrogastric intussusception as a complication of a prior gastric plication. Here are the relevant disclosures that our authors have for the past 3 years. Great. So laparoscopic greater curvature plication is a weight loss procedure in which the greater curvature of the stomach is mobilized, folded in on itself, and then secured with sutures. It's not widely performed in the United States, and it's still considered investigational due to the lack of long-term data. Studies of outcomes so far have shown slightly inferior weight loss compared to sleeve gastrectomy with higher reoperative rates and long-term weight regain. Complication rates can be between 8 and 32%, and can include gastric obstructions, fundus prolapse, nausea, vomiting, microleak, jejunal necrosis, and GI bleeding. So we present the case of a 33-year-old woman with a history of gastric plication 2 years ago in the Dominican Republic, who presented to us with 4 days of epigastric abdominal pain, dry heaves, and diarrhea. She was hemodynamically stable without a leukocytosis and had some mild epigastric pain. An abdominal ultrasound was concerning for intussusception due to the bullseye sign as seen on the right of this screen. So CT imaging was obtained, and radiology actually read it as a gastrogastric intussusception of gastric pouch in bypass anatomy with thickening and edema of the gastric wall. So the decision was made to proceed with a diagnostic laparoscopy, ultimately requiring endoscopic reduction of the gastrogastric intussusception and then the laparoscopic takedown of the plication. So we started by entering the abdomen laparoscopically with 4 ports placed in the positions that you'll see in a moment, as well as a liver retractor subxiphoid. And then an additional 5mm port was actually placed later in the case for retraction purposes. So on our initial inspection, we noted gastrogastric intussusception with the proximal plication actually intussuscepted into the antrum of the stomach, causing essentially a gastric outlet obstruction. We attempted to reduce this laparoscopically, however, it could not be reduced despite our best efforts, and thus endoscopy was performed. So upon entrance into the stomach endoscopically, we found the plication to be invaginated into the gastric lumen. Our thought was that in insufflating the stomach, we could reduce the intussusception, similar to how lower GI tract intussusception is reduced with air enemas. So the invaginated portion of stomach was traversed, and eventually we were able to identify the pylorus. And then using some retroflexion and insufflation, the stomach we were able to successfully reduce the intussusception. And there you can still see the plication still present. So we then switched back to laparoscopy to try to take down this plication just to prevent any reoccurrence. So takedown began on the lower part of the greater curve, and then using sharp dissection, we took down the sutures and associated adhesions that formed the plication. We also used an energy device for areas of thicker tissue which were prone to bleeding. Some of the areas of scar tissue as we ascended the greater curvature were prone to some unavoidable bleeding, as you'll see in a moment, and our energy device and sutures were used in combination to ensure good hemostasis. And then after freeing the lower aspect of the greater curvature, the plication was still intact more superiorly, so our attention was then turned to those attachments. To further guide which areas of the plication still required takedown, we performed intraoperative endoscopy to determine if the superior or inferior attachments were still intact, and thus we reconfirmed or we continued our dissection accordingly. Here you can see the superior aspect was still intact, so we continued to dissect there. So finally, the last portion of the plication was successfully dissected, and our plication takedown was complete. An endoscopy was performed at the conclusion of the procedure, which showed no obvious leaks and a widely patent gastric anatomy. So post-operatively, an upper GI contrast study was obtained showing no extravasation or leakage, and by post-operative day 1, she was tolerating clear liquids and discharged home. Her 3-month follow-up endoscopy is shown here with healthy-appearing mucosa at the bottom of the screen. So gastric plication is an uncommon weight loss procedure with limited long-term data on safety and some complications unique to the post-plication anatomy that require gastric plication takedown. Endoscopic reduction is an effective treatment strategy for this type of gastrogastric intussusception. Despite the rarity of this procedure in the United States, surgeons should be aware of this plication anatomy and therefore the treatment of gastric intussusception. Thank you, and I'd be happy to take any questions.